topic. And now we are moving on to a nursing topic. And you have to understand that nurses has a very important role to play in palliative care. Actually, maybe the nurses have a major role than doctors in doing delivering palliative care services. Um, so today we are looking at two important topics in wound management. One is the pressure sore and the other one is fungating ulcer, which is very common in patients with malignancy and patients who are better. So today the session will be handled by uh, Mr. Immaraju Swarup, who is a nurse, and uh, he he's a nurse trainer in Indian Palliative Care Society at Hyderabad, and he's also the nursing surgeon at Kumudini Devi Hospice, and he's also working with the neonatal unit of Nilokar Hospital, Hyderabad. Uh, he has been a part of implementing palliative care units in Telangana. Uh, Telangana. So, uh, welcome, Surup, and it's over to you.
Thank you, sir. Thank you. Thank you so much. So, can I share the screen from my side?
Yes,
I hope I think so. I can. Yeah. Thank you, sir. Okay. So, very good afternoon to everyone. It's very nice and very happy to see you all here. So, as a part of your training, the management of wound and this fighting wounds, and what is our management. So, apart from what we do till now, different in palliative care. So, kind of exposed to really the patient's need and the family need is. Am I not audible?
Your voice is breaking in between. Can we off your video?
Yeah, is there any? I will do that. Thank you. Yeah, I hope it's clear now. Am I okay? Okay now?
Still the voice is breaking, Surup.
Yeah.
Moment. I hope that's okay.
Yeah, it's okay.
Okay, so today's case, thank you first of all, good afternoon to everyone presented here. Thank you so much for the opportunity to present this case. Regarding the topic of wound management, I thought of choosing this patient that we had seen in our hospital. We get quite a few patients with burns injuries. So I thought of presenting this case in relation to the topic. The case is that of a 22-year-old lady who came in with second and third degree burns involving the right lower limb. It's approximately 18% of her total body surface area. So her chief complaints per se, again, alleged history of burns sustained over the right lower limb. Approximately 2 to 3 hours prior to her arrival, she had severe pain at the time of presentation. Next slide. Yeah, and she described it as the worst pain she's ever felt in her life. And she also was unable to move the limb at the time because of the pain. So as the history goes, in the next slide, she was performing a puja at her home, at her residence, when her pajama caught fire. And immediately after dosing the fire, they arrived at our hospital. Their house was quite far off from our hospital. So it took them roughly 3 hours to arrive. She was apparently well prior to the incident. She had no other complaints, no other comorbidities as such. She has no history of substance abuse. And commenting on her dietary habits, she's non-vegetarian. So on her examination findings, she was conscious oriented at the time. Next slide. She was tachycardic on arrival, but the rest of her vitals were more or less unremarkable. Systemic examination also did not show any abnormalities. On local examination, she had second and third degree burns, mainly affecting the right lower limb. The anterior and posterior aspects were affected all the way from the upper thigh up to the ankle. Her perineum was spared, and there was blistering of the skin present. Her sensations were intact more or less over the area. So moving on to a treatment, in the next slide, at admission, we immediately administered fluid resuscitation using modified Parkinson's formula for the first 24 hours. We gave a basic analgesics like tramadol, paracetamol, and diclofenac. Phenagon was just given as an antiemetic. We had sent basic investigations for her. We had started her on antibiotics and given her a simple dressing with normal saline and Vaseline gauze dressing. At this point of time, we had to explain to the patient the severity of the situation, that she would require multi-specialty care, and at being a secondary care hospital, we actually are set up in a rural place in Bihar. So we don't really have a burn specialist or a plastic surgeon in our hospital. We have a general surgeon. So we had explained the risks of sepsis, especially that increase the mortality of patients with burns. So we told them that they might have to go to a higher center for the treatment, especially if grafting was needed. But considering the current situation of the COVID pandemic, they were forced to have stay here. They wanted to continue treatment over here. So we acknowledged and proceeded with treatment. So during the course of her stay, the next slide, uh, we had to do twice a day dressings for her. She required twice a day dressings with normal saline and silver nitrate cream and Vaseline gauze. There was quite amount of slough buildup, especially during the second week. So this was quite troublesome for us, and this is the reason why we had to try and speed up the clearing of the wound to improve granulation tissue growth. So we had taken up the whole twice a day dressings. We had put her on round the clock analgesics, timed the analgesics so that it would be close to the timing of her dressings, so that her pain would be as minimal as possible. We had encouraged her to continue on a high protein diet, to hydrate herself, and encouraged her to ambulate as much as possible to prevent any stationary movement and not completely be immobilized. Um, at this point, as I mentioned before, she continued to have excessive slough buildup despite her being on antibiotics, despite the dressings, and she even required wound debridement twice during the course of her stay. And there was a significant drop in her hemoglobin also during her stay. This is why she required 2 units of blood also to be transfused. But thankfully, the wound healed. There was significant granulation tissue, and we could take her up for a split thickness skin grafting just a few days back. It happened. So, God willing, it's gone well, and we're hoping that the skin graft takes up well. And one thing that I wanted to highlight was a certain thing we call biofilm or amnion dressings that we do over here. These are mainly done to reduce the need for daily dressings. So I'll be going into detail a bit about that in the next slides or so. Uh, so in the next slide, as you see, this was around day 2 of her stay when she had come. There's a significant amount of granulation tissue, but a lot of scar tissue and minimal slough also present. So it was already a daunting task, but it seemed, despite our efforts, it seemed to be getting worse. In the next slide. So as you can see, quite a bit of slough was developing. We tried to scrub it off. It was often painful for the patient, despite the analgesics that she was receiving. Unfortunately, our hospital doesn't have the license to store or administer strong opioids, so we did not have drugs like morphine or fentanyl at our disposal. We had to make do with tramadol and paracetamol and diclofenac. So she endured quite a bit of pain during her dressings, but remained relatively pain-free at the rest of the time. This even required wound debridement. However, one thing that really helped her during the stay was the use of these amnion dressings, so to speak, which I'll be showing the next slide. So once the debridement was done and there was significant amount of granulation tissue, we were able to put what we call as these amniotic dressings. So this was actually taught to us by a plastic surgeon who had visited our hospital roughly 3 years back, and he had shown us a method to extract the amniotic membranes from the placenta using a sterile method and preserving it. refrigerating it and using it on wounds with relatively healthy granulation tissue, so that we would minimize the need for daily dressings, and that way the patient can still mobilize, and the healing would also be better. There would be less slough development. So it looks a bit messy when you look at it from the photo, but once it heals, it literally looks like a thick layer of uh, leathery skin. So when you go to the next slide, the picture on the left shows a dried up amniotic membrane dressing. So you can see that most of it, the dead debris, the cells are actually collected within the dressing. And at this point, the patient doesn't have to undergo any more dressings with gauze. They can just move around freely. They can go about their daily duties. She was able to do everything that she could, including go to the bathroom. And slowly, after 3 or 4 days, the dressing by itself would come off. And along with that, whatever slough and debris would, and it would end up looking in 2 or 3 days after that as the photo on the right, almost red granulation tissue with minimal slough. And with this in mind, we were able to take her up even quicker for a split thickness skin grafting. Uh, so what basically what goes about this is it should have been done faster. Unfortunately, we weren't able to get the amnion graft uh, faster than when she came at the time she was coming, because we usually get it from our elective cesarean cases, and our hospital has been getting less patients now because of the COVID pandemic. So we didn't have a graft ready for her when she came immediately to the emergency, which would have been the best time to put the graft. So that was one regret on our part, but thankfully it still helped her in the run, and she underwent a good healing and was able to be taken up for the graft. So moving on to the next, her psychosocial aspects. Uh, right now, she's currently doing her BA in sociology. It's a second part. She belongs to a middle class family, but currently they're going through a little financial struggle, especially during the COVID time. Her father mainly sets up, he has a setup for irrigational facilities for different agricultures, and her mother is a homemaker. She has three younger sisters and a younger brother. All of them are in school right now. The eldest of them being in 12th, and the youngest being the brother in 5th. She's currently unmarried. Moving to the next slide. The medications that we used mainly include the antibiotics. Ampicillin, gentamicin remained the mainstay of her antibiotics. She did not require any escalation. Thankfully, she did not develop any signs of sepsis during her stay. And analgesics were tramadol, diclofenac, and paracetamol. We used antiemetics because there were times when she did feel nauseous. We were unsure whether it was because of the tramadol or maybe her diet. Also, there were times when she wasn't really eating that well, and she had lost a significant amount of weight also during that time. So we had to administer antiemetics. She received gastroprotective agents like pantoprazole, multivitamins like vitamin C, neurobion forte, and even silver nitrate cream and mupirocin ointment were used mainly for her dressings. So moving to the main concerns, the next slide. The main concerns that we had, that she mainly had, was the pain during her dressings. So despite our best efforts with whatever we had, we were unable to relieve her pain during her dressing. She would face extreme amount of pain, especially while we were trying to remove the slough. And it was a tough time. It was a tough time counseling her. She was always worried about how long it would take, and her dressings would take around 20 to 30 minutes at least to do. And it was very troubling for her, but she was very strong-willed. She was very determined, and thankfully she managed to get through the pain. And she was also worried about the full recovery, about the chance of the scars. We had explained to her that she may not get her full, the skin may not look exactly as it would as before. It may maximum be only a 90% recovery. So she was worried about how the scars would look. There were financial worries on her parents' side about how they would manage the treatment, because they were explained that the course of stay would be quite long, at least 1 to 2 months. Thankfully, it's been a little less than 2 months, but that was also on their minds. And of course, marriage, being unmarried at her age, also the family was also worried. They also have, she has younger siblings, and those were also things on the concern of their family. So she required a lot of counseling during this time, but we were happy to say that at least during this time we were able to guide her and counsel her during a time. There were fun times that we had. Surprisingly, during her dressings, we were able to joke around as well during her dressings and alleviate some of her pain. So, but that still remains one of our concerns and points of discussion, especially as we move on. So, to the next slide. The summary would be a 22-year-old lady with second and third degree burns who's unable to seek treatment at a higher center due to financial constraints. Her main complaints of unbearable pain, and she was managed with daily dressings and taken up for a skin graft finally. She's still in the hospital currently at stay. So our discussion points that I could think of was, could the pain relief be improved, uh, especially considering the situation of unavailability of strong opioids? Is there more we could do? Was there something with the timing of the analgesia? What more could be done to reduce the hospital stay, especially for patients with burn dressings? We get quite a few patients with burn dressings who end up staying for 1 or 2 months before their wound gets better. Are there any other approaches to wound dressing that can reduce slough buildup, or any medication that we could use? And how better to counsel people, especially people who are vulnerable during this day and the pain that they face? How do we counsel them during this time? So these are points that can be discussed, that I thought could be discussed during this time. Yeah.
Thank you, Dr. Joseph. So, directly did Swarup join,
Yes, yes.
and his voice is opening. Is audio?
Swarup, sir?
Yes, I'm available.
Yeah. So, so I hope you had the case presentation. Uh,
Yeah,
so,
okay.
yeah. So I think, are there anybody who works in acute care setting? Are there a surgeon in the group, or somebody else who is experienced in burn management? Or else, please have your comments on dressing, because people who work in palliative care will not be experienced in bone dressing in burns, but we are asked to see patients for pain, especially in burns. So I'm not experienced with the dressings in burns, but if there is anybody who is experienced, please speak. Dr. Melita says Belarin dressing. Dr. Melita, can you unmute that?
Yes, actually in our hospital, we do have burn cases and even pediatric. And these dressings are very effective, but they might be a little expensive. So there is no need to put any ointment or anything. Just after debridement or cleaning, we just wrap the wound with this melanin dressing. These are large sheets of melanin covered on one side, and on the other it's just cotton and gauze. So the melanin side faces the wound, and there is very effective recovery, and we've seen patients go back even with 45-50% burns,
Okay.
and the hospital stay is also reduced.
That's good. Dr. Jorgen, have you seen Belarin dressing?
I'm sorry, ma'am. Did if I correct me if I heard you, did you say melanin dressings, person?
Yeah, Belarin dressings.
Okay, I'm not I'm not sure.
I think the spelling was wrong. N-E, I think it's not A-I-N. It's any melanine.
Oh, melanin. Okay,
Yeah,
I'm not
yeah.
very familiar with that, ma'am. Actually,
Okay.
because the ones we use here, they're also very cheap. We basically extract the amniotic membrane from the placenta. So it would
Okay.
cost the patient simply the one bottle of normal saline, which we would use to clean the membranes, and one pair of sterile gloves. That's all it costs for the dressing, and then they don't have to undergo any of this thing. So they don't have to undergo any further gauze dressings, and the healing is also faster, and they don't need to go through these dressings. So that's very helpful for these patients here. And we don't really have any other means over here, especially in our settings. So this is what we were taught by plastic surgeon who came here. So it's been very helpful for most of the patients. Unfortunately, I will be honest, we can't really, but we do explain to the patient that this is, we call it biofilm, but we never really elaborate on what it is, because if the patients actually know what the dressing is made of, I'm not sure they will agree to take part in the dressing, as helpful as it is to them. So
Anybody else have any more experience? Yeah, Dr. Durgan, there is a question for you. How do you how do you store this medicine? Yeah, I think Dr. Durgan already talked about that. They will take it and store it in the refrigerator, isn't it? Dr. Durgan?
yeah, we basically store it in saline. We use some gentamicin drops as well, just as antibiotic prophylaxis, and we refrigerate it. So we try to be as sterile as possible, because we don't want to add more infection. There's already a risk of sepsis to these patients. So as much as possible, and we only use extracts from our elective cesarean cases. We cannot use emergency cesarean case patients because of the risk of sepsis. So that's how we store it.
Yes, yes. Anybody else? I say it's Melodin. Melodin.
There was a question of how often we have to change the dressing. So it usually we change it after maybe 3 to 4 days, but it depends on how soon it comes off. The moment it comes off, we try to get a graft as soon as the next case comes, and we just apply it on top of that graft. So it's a continuous process. As soon as we get more, we just put it on. So it's basically within 3 or 4 days. It lasts around 3 to 4 days.
Okay. So Dr. Meera was telling that using this surface anesthesia, dignity, but there is a problem with dignity because this is 18% dose, so a large area have to be uh, actually applied with dignity. So the dosing may be higher than what is permitted. So maybe if it is a small area, it would have been a very good idea. But for larger areas, we have to also look into what is the maximum dose. Okay. I hope I am audible. Honestly,
Yes, sir. You were audible, sir.
okay. Uh, and what else? Dr. Durgan, you told that you were using tramadol. How much tramadol were you using per day?
So we were using 50 mg Q8 hourly, sir. So it was around 150 mg of tramadol. Her body weight was
Okay.
roughly 35 to 36 kilos.
Oh,
Uh, so I wanted to know if we could go a little higher on the tramadol, but even when we timed it, she still had pain during the dressing. She was relatively pain-free otherwise, she never felt too much pain. Otherwise, she was able to ambulate and do all her tasks, go to the bathroom. But during the dressing, it was a painful time, despite this thing. But the question of the dose of tramadol, yes, could I have gone higher with 50 mg of tramadol? We had 50 mg of Vovran going Q8 hourly, and paracetamol was going 1 gram Q6 hourly.
I think you can definitely increase the dose of tramadol, and we have to consider her as an adult, 22 years, even with she has a low weight, but still we can use up to 400 milligram. But anyway, you are using only 150 milligram, and we give 50 milligram of tramadol IV before maybe 45 minutes to 1 hour before the game dressing.
Okay.
And how is her renal profile?
So her renal profile was fine. So her creatinine was stable. It was usually 0.3 to 0.4. She didn't have a severe dehydration, so her electrolytes were also fine. So fluid resuscitation was sufficient in the first day, and she, except for her hemoglobin dropping, the majority of her parameters were fine. Even her counts weren't really elevated too badly.
Mhm. So anybody has any more suggestions? On pain management?
Morphine in that scenario, parenteral morphine for the dressings and all that.
Yeah. The problem is that Dr. Durgan doesn't have any strong analgesics like morphine or fentanyl. So he has to manage with tramadol. Otherwise, as I told, we would have gone for.
Well, suppose we do have it. They do have it. They can use it, no?
No, his hospital it is not available. Dr. Durgan, can you get oral morphine from some of the centers nearby your hospital?
Actually, sir, not that we know of. So in Bihar also, we don't know any places where we can get morphine as such. So we had access to pentazocine, but that also weren't able to legally administer. So that was also off the charts for us. So sadly, because of that, and the policies are very strict also in Bihar. I'm not sure if they even if it's available.
Okay. So yeah, you can increase the dose of tramadol anytime. And I'm little worried about the NSAIDs in burns because there is a chance of renal failure. So you will be better experienced than me in critical care situations.
Yes.
But and there is a chance of inducing renal failure. So it should be frequently monitored. And if morphine or fentanyl was available, definitely we should have used that.
Yes.
So that's a better option. Swarup, do you have any suggestions?
No, sir. So these are all very rare dressings for us. So we don't even involve. We have another center where we send such patients for the wound management. Meanwhile, for the pain management, we can just go through that. Like what sir said, we also follow the same, and sometimes we go up to the morphine even. There are few burns cases like that.
So, Dr. Durgan, you were talking about the counseling of the patient. So, what exactly did you mean by counseling in this patient? Can you elaborate?
Yes, sir. Well, for her, she was she was very young. She was not, she's never gone through such an instance before in her life. It's the first time something like this has happened to her. She was very traumatized mentally also, and she couldn't imagine something like this would take so much time, and the pain also was unbearable. So the counseling I was referring to is just daily, I guess, talking and ministering to the patient and trying to support her and encourage her and not to give up, because there were many times that we felt that she was giving up. She was refusing to eat food. She just wanted to lie down the entire day. She did not want to ambulate. So we tried our best. We prayed for her at times when she requested, and it was tough for her because we couldn't imagine the pain she was going through. None of us had been through that, so we would be honest with her that we couldn't imagine the pain she is going through, but we could only be there for her as much as possible. So it was tough for her, and I guess that counseling mainly. Is there anything more we can do? We were there for the patient, and I'm glad to say now she was very happy with the treatment. She almost became part of the hospital, you can say, uh, at one point of time. So uh, I felt it was sufficient, but there were points of time where she was not satisfied, where she felt it was taking too long, and even we didn't have the answers for her. So I guess maybe in that sense.
Yeah, that's true, Gagan, because when the patients are suffering, even if we do all the possible things by us, they may not be satisfied. But after some time, when they look back, they will understand, oh, they did it for me. And even if I have gone to another hospital, uh, even this care would not have been available. So I think in your situation where other strong analgesics like morphine or fentanyl were not available, then I think it is all what you have did is right. Make a good rapport with the patient and be with the patient and talk with her and tell her that this is what we are trying to do and we will take out the testing in a uh, in a way that it will not cause much pain to you and things like that. Even the words and your attitude towards her will make her comfortable, even though she is into you. And of course, the dose of tramadol can be increased and it can be used before addressing pain, uh, 1 hour before the symptom. And post-traumatic disorder is something which can occur after some time. Uh, Anybody want to add any more points? Okay. So some of the points were usage of, and I also see there is collagen dressings which can be used. That Gajas have database since collagen dressing, collagen sheets. Okay, and we have already talked about uh, the nicotine that also 20 or it would be high if we are going to use it for a large surface area. So it might be for the patient. And Dr. Seswaran also says we can do it under general anesthesia with ketamine. Yeah, those are awesome and definitely increase the dose of tramadol, because it would be the most suitable thing in your situation that we can do. Uh, my voice is not clear. Rajalakshmi,
Sir, we could hear it.
okay, I don't know. Somebody saying it's not clear. So I was telling that in Dr. Jurgen's situation, increasing the dose of tramadol would be the suitable thing, but we can also keep in our mind the use of general anesthesia at the time of dressing. Lignocaine is suitable for lignocaine local application will be suitable for small wounds, and there are many types of dressing, but Dr. Durgan and his team done it in a very innovative way, like harvesting the placenta and putting it on the wound. So melanin dressing and collagen sheets are other options, and it is important to keep the patient updated regarding what is possible from you, and listen to her and be with her during the procedure. So those are some points that we discussed. So I think we can move on to the topic now. Sir, it's over to you.
Yes, sir. Yeah, thank you.
Sir, should I share the screen?
Yeah, sure, please.
Thank you, sir.
I'm just connected with my phone, so there's a problem again.
Okay.
Yeah, please. Yeah, okay. Good afternoon, everyone. And once again, I'm sorry for the delay, what happened. Meanwhile, as a part of our training in palliative care, so this is also one of a topic where do really think the doctors have to do that or not, it is up to us. But somewhere I feel that most of us has to take that responsibility as a leaders of your palliative care units where you start or wherever you work. It's important for the even the doctors also to know what exactly the wound is. I can just give an example of what really happened in few places where I met. So the doctors are not aware of the wounds, and all of a sudden the nurses have faced a problem that okay, these wounds are being unhealed, and it is it also has a lot of pain and a lot of discharges and bleeding, where you see the quality care of the patient has gone down just because of these problems. So somewhere I feel that so doctor should take that responsibility and at least to see what is happening and guide the nurses so that is how we implement the wound management in all of our centers. So okay, I'm going to start my discussion now, and also thank Sunil sir for a very good introduction. Thank you, sir. Thank you so much. Okay, can you please go for the next slide, please? Yeah, so I would like to start off with the case history, a brief information of one of our patient, a subject named X, and he's a 40 years old male, an auto driver. So many times we see it in a different way that, different age groups have different problems. So I have mentioned a few points with the bold letters where wound management is not just a physical management. It also involves a psychosocial, spirituality, everything considered in that. Like when you talk about the pain, we call it as a total pain. As the same, it also been considered as. So diagnosed with the cancer of right buccal mucosa, with developed wound over the right side of the face and presenting with the foul smell, pus discharge, and bleeding from that wound. So patient lives in remote areas and from the very poor financial background. So also
Sir, you're muted.
the question, no, sorry, there was some problem there. Okay, so the question is, so how are we going to treat this patient and how are we going to help this patient and the family? So majorly, like when we started palliative care units here in the state of Telangana, right now we have at least achieved somewhere around some 16 centers in the state. So which is a huge number to say. But every center we go, a lot of patients are from the remote areas. So the one with the well-off and very good background, they go up to the super specialty hospital. So the question is, what do you think these kind of people can go to? They just go to the government hospitals. That's all. Other than that, there is nothing more. So sometimes even they don't even get treatment there. They go back home with the very bad and worst stages at home, and they die just with the very poor quality. So as a palliative care team, what are we going to do? That is what the question is. So what kind of care plans could be helpful for such patients is another question. Let's go back to the next slide, please. So in this discussion, what are we going to learn is number one, so a brief information about the wound
dressing. And number two, the definition, the characteristics, and what is the major treatment for the fungating wounds, and what is the management, and what is the emergency bleeding kit is all about. Next slide, please. Okay, so wounds have been one of the major problems in end-of-life patients. You see, they develop bed sores, a type of wound, and also they develop wounds in different parts of the body in many other cancers. As same, so few data has been reported that 35% of hospice patients were affected with the wounds. In our center, we have a 20-bedded hospice here running in Kukatpalli, Hyderabad, where out of 20 beds, we have 16 to 17 patients. In that patients, more than 7 to 8 patients are affected with the wounds, and they all need the wound management, which is to be followed up by the family members. So we are not the people to treat them. So the government of Telangana has initiated to take a responsibility of educating the families. When I do it today, how the family can do it at home. So this is what the main motto of our state of Telangana is. So we see such patients, like 35% of hospice patients are admitted, and there are with the different types of wounds like surgical stasis and skin tears and tumors too. Yeah, next slide, please. If you can see on the left top end of the screen, there is a patient with oral cancer, buccal mucosa, and you see there is a fistula developed at that side. So, for example, if this patient would have come to us earlier stages itself, we would have managed his wound very well. So he developed it just because of maybe due to the disease, but somewhere I see the poor quality care. There are a lot of anticipatory plans for such patients. On the right hand side of the top end, there is a patient, so one of our patients with a breast cancer, and slowly she developed lymphedema, and slowly it has been spread all over that particular limb, extended towards the chest and the shoulder too. And over the middle, you can see a huge wound, which also looks like just a cauliflower, and somewhere it has also been bleeding. You see some pus discharge is also been there. So it just means that there are different types of wounds we see, but most probably we might not have seen such patients till now. But somewhere when you come up to the palliative care, you can see a lot of such patients in. So when there are people suffering in front of you, it might not be the thing that you can cure everyone. So it is not our motto at all. Out of what they have, what kind of quality can be provided to them? This is what our motto should be. So out of all these things, what kind of quality care, how do we improve the quality is all we can do. The next slide, please. Okay, so here a gentleman is presenting with the wound, which is very bad. You can see a lot of patchy layers over there, and you see the lips have been swollen. On all the other sides of the face, which is close to the wound, is also been swollen. So it just means that just by describing one picture here, I can say that this patient is suffering a lot. There are a few things which is making him more horrible. Number one, talk about pain, because when you have a inflammation, infection, and swelling, that itself means that he's suffering in pain. I'm not sure his oral care would be good. I hope that it is worst. And on the other side, when you talk about the disfigurement, it has also been bothering him. So a lot of pain, discharges, bad smell. So when you have a very bad smell, really, you could not be comfortable talking to your family members, eating food in time. So a lot of issues might happen to them just because of a lot of pain who could not sleep, a lot of pain who could not swallow feedings. And sometimes I'm surprised that sometimes this patient can also have just due to the fistula, the food which is taken by the mouth can be leaked out by the wound itself. And a lot of discharge you can see there. So picture itself describes a lot of information to us. Let us go to the next slide, please. Okay, this is a small definition of the wound. So break in the integrity of the skin or the tissue, often which may be associated with the disruption of the structure and function. So the condition of proliferation and ulceration, so which is arise from the malignant tumor cells and infiltration through the skin. Next slide, please. Okay, so before we go on to the next discussion, So remember one thing, we are not here to heal the wounds. So the case presentation which was presented, maybe that patient will surely be healed. But when you talk about the malignant and the fungating wounds, our motto is not to cure the wound, but we are not going to heal that wound. But only thing is how to manage and continue with the good quality care. Next slide, please. Okay, so when you just talk about the wound, when you see the wound, these are all the goals and actions or aims should be like infiltration of the skin and blood vessels, the depth of the infiltration, number one. So the malodor, redness, and look for the swelling. Yeah, next slide, please. Okay, the management action plan. So what are we going to do when you see a patient with such a wounds which are malignant and fungating? Our main motto is to make the patient comfortable, not to worry more about that. Number one, reduce his anxiety in the sense, worry in the sense. So I'm not talking about the wound or the healing process at all, but somewhere the patient would be more worried or anxious about the social interaction. So he don't go up with the society, he don't be in touch with them. So the family is also not so close to him. So there are a lot of issues with that. So the main goal is to see and talk to them, number one. And next thing is control the bad odor, control the exudate, the discharges, and sometimes the patient may also develop bleeding. We are going to talk about the bleeding management in palliative care too. And on the other side, pain management is also one of the major part of this. So shall we go back to the next slide, please? Next slide. Okay, so the management action involves, number one is assessment. So how do we do this assessment? So what are the plans for this assessment? Second point is the wound care. So what type of dressing is supposed to be done? If it is a hospital based setup, that is completely different, and the home based setup, it is different. I'm just specifically mentioning the home based plans. It is all just because, so once you are in the hospital, that is okay for everybody to do it just like that. And once the patient has been discharged, so how do we really manage such situations? This is what an action is. So do the family have to depend on someone, or they have to do it on their own? So when you talk about that, it is important for the family members to get educated, and family has to do it. So wound management and hospital based and the home based management. And next is the pain. So how do we control the pain? Followed by a good education. Let us go back to that. Okay, next slide, please. Okay, this is a brief information about how these fungating wounds are. These are the results of the cancerous cells in the cells infiltrating the skin, and it's supporting blood and lymph vessels. So loss of vascularity and leads to the tissue death. Next slide, please. Okay, next slide. So the management plan, as I told you that assessment plays a major role in that, planning and implementation. Sometimes when there is no proper plan, there is nothing you can do. So there are a lot of things would be missing in that. So why are we planning for that is the patient should be prepared for that dressing, number one. Number two, the family should also be involved in that dressing. It is not that the hospital team only have to do it every day and followed by leaving up to the family once they are getting discharged. Once they get discharged, the family should have all the efficiency to do the dressing. That is what so implementation. What so talk more about the basic techniques and the good techniques which the family can do it at home. As I told you, a lot of people from the remote areas don't just assume that they can do it every day. I see a lot of patients who are on the hospital setup with a very good equipped bed. Like we also have a very good beds in the hospital. Once they go back home, the same patient was discharged. I have seen the patient back in the home again other day. So he was lying down on the floor. So when you are doing such techniques in the hospital, and when the house setup is completely different, so there is no point of you telling all this hospital-based position changings and exercises. So which this really doesn't make much difference. So try to think about talking or involving the family and knowing more about what exactly it is. An explanation to the patient and caregivers and the consent. When you talk more about the wound management or the dressing plan with the patient and the caregivers, they'll try to cooperate with you. when you don't talk about that and you go and just do the dressing and come back, maybe the day is completed, but on the other side, patient is not so comfortable. So what are his wishes, and how does really he want the dressing to be? Sometimes if the nurse is coming and flushing it with the syringe on the wound, and it has been spread all over my shirt or my clothes, which are contaminated. Really, if I don't like that, even the small wishes of the patient also has to be considered. Sometimes I would like to go out to the washroom and clean my wound and come back. If that is the patient's wish to do, and we have to follow that even. So as the same, even the family has to get involved and explain how it is going to be. If if the patient is having a lot of pain in the wound site, so give some time, go for the other plans. Setting up, so setting a good time, telling the patient to go up to the washroom, give him a time to discuss about that, so that they'll come forward and ask you a lot of questions. So during the dressing, just spend some time in talking to them. It's not a machinery to just go and do everything and come back. It's also human beings. So maybe we may have to talk to them, tell them how it looks like. Okay, are you scared of this? What did you have? A lot of discussion. The removal of the dressing, how to remove that, and the cleaning, evaluation, and a good documentation. So education about the self-care and for the caregivers. So this last point plays a major role in our place, where a lot of patients are from a very far away centers. So coming back to the state of the city of Hyderabad, it is very hard for them. So we try to tell the family to learn more about the wound management at home. So they go forward and start doing it. So it is a time for them to learn everything here at when they're been admitted in the hospital itself. Next slide, please. In our assessment, number one, look at the site. Where exactly the wound is. How does it look like? Is it a reddish in color? We have seen few pictures before in the last slides. So just by looking into the picture itself, we'll come to know how bad or how worse these wounds are being. Based on that, you can just mention, okay, this is the site where it is. Number two, size of the wound. For example, the circumference of the wound should be measured in horizontal or perpendicularly. So sometimes we see in a scanning reports, the tumors are being measured in a way that 15 into 5 centimeters. So it just means that, okay, the size of the wound is this much. We all know that the centimeters. So 5 into 5 is nothing but in the circumference, it comes into a very smaller size, somewhere like a tennis ball. So 5 into 5 centimeters is that. So based on that, we'll come to know how big the size of the tumor or the wound is. Number three, look for the color. How does it look like? Is it a bad or a black fungating or a necrotic tissue there? Or is it red, making the patient more worse? Smell. Are we going to deal with all these things? Means yes, we are going to deal with each and every slide of this. So pain management and bad odor. Sometimes we see such patients with a very bad odor. I'm going to discuss about that very soon in the next slides. So pain also plays a major role. A lot of our patients with the wounds have a lot of pain and bleeding. Specifically, look for the spurting. Is it a steady flow, oozing, or external or internal injury? Look for that for bleeding. And any discharge, any watery discharge or the white discharge, or any pus discharging from this wound. And also take a picture for a better care and improvements. Every time we do the same. In our hospital, we also have a medical officer where he comes every day to our department. Every third day, he comes out to see the dressing. That is what we have implemented. Every third day, he'll come have a look at that. So how often he comes in to see that, he'll have an information of changing the medications, changing the plan of action of the wound management. If you have a picture of day one of admission of the wound, and after a week, take another picture. So these two pictures has to show you a difference of the experience. These two pictures has to show the management plan and your goals of your wound assessment and management. So picture plays a major role in that. If after a week, you see a lot of differences, it was very red and huge, bad smell, fungating. If you take a picture of that, maybe after a week, all your plans, all the measures you have taken in caring that patient, in managing the patient's wound should be helpful. Even after 7 days, if it looks the same like the day one, there is no point. There is something wrong from our team, that might be we are not doing the dressing regularly, or skipping the time, or the patient is not so comfortable doing it. He might have a lot of pain and he's not so cooperating. So if such situations, the pictures can show you a lot of information. Also, maintain a good wound management chart in the file. On the day of admission, when you see the patient with a very bad and fungating wound, like earlier we have seen them, okay, have a graph of information of how bad the smell is. All these questions may arise in that. How is the pain in the wound site? Is there any bleeding? Score it from 0 to 10. Mention a chart. Every day you may have to, after your dressing or during the dressing, you may have to observe how bad it is. Is there any pain? How about the smell? How about the spreading of the wound? Is there any bleeding or any other symptoms have been identified? When you have that documentation, every day when you do it, our main goal is to reduce all those symptoms. Maybe the pain, the bleeding, not any other discharge from that side. So this is all you have to maintain. Yeah, next slide, please. So the steps of the wound dressing, followed by number 1, removal of the dressing plays a major role. So when you start removing the dressing, the old dressing, which was done yesterday, when you're doing it today, should be removed very gently using, so spreading some water over that, the normal saline over that, soak it well in the water, or the patient even can go out to the washroom if he's able to, go out, soak it well, come back and gently remove that and just cover it up. So that will be more easy for the nurse to go forward for the dressing. Number 2, cleaning the wound. How do we clean the wound? Cleaning up with maybe using a forceps with the cotton pinched in and cleaning it with that. Maybe somewhere I feel that patients may have a lot of pain when we are doing the dressing. Have a talk with them once. Tell them that, is it more painful when I'm doing it? They'll surely have it. So what I suggest is, use a glove, wear a gloves, take some gauze pieces in your hand, gently rotate it well, discard the pads, dispose them. So when you just do it very gently, that will be more comfortable for them. Instead of using the forceps directly on that, it is more painful. And sometimes it itself may leads to a lot of pain. So we have to be very gently, do not squeeze it, very gently clean it. So in the earlier slide, I have told you about, we are not going to heal that wounds. That is true. We are not here to clean it every day and look for the healing process there. There is nothing we can do. We are just looking into the quality care. Okay, the patient has the incurable disease like one of a cancer, and he developed the wound with there, and it is not going to get cured. And one day, sometimes the patient may also have a bleeding tomorrow. So to prevent all these things, we are here to explain the whole pattern of actions to the patient and the family, and we can implement that. So the family should not feel that, okay, the treatment plan has started. Okay, he'll be all right. He'll be cured out of disease. So take out the these kind of aspects from the patient side. So cleaning the wound with a normal saline. So I'm going to discuss that later on, and applying the new dressing. These are the few steps I'm going to discuss later. Okay, next slide, please. Okay, so about the dressing procedure, there are 4 steps in this. Number 1, every time when you do the dressing, there should be a pre-medications. As I told you that patient will surely experience pain. Sometimes they are more worried about the pain and they don't want the dressing to happen. Few of the homes what I've seen, the family says that the patient is not allowing me to do that in the home. So as a wife, my husband is not allowing me to do the dressing every day. So that's the reason why I am doing it on every 3rd day. And that too, she is doing it very gently. Every 3rd day, these are the fungating and bad necrotic wounds, which has to be cleaned every day, flushed every day, and the dressing has to be changed. If the patient is not accepting, what would be the reasons? Look for the reasons. So maybe this lady was not well trained in that. Just because of pain, the patient would have not allowed the family members to come in to do the dressing. They're just postponing it. Somewhere the patient may develop a lot of infection again, and it leads to pain. So the pre-medications, like the family has to be taught with that. I'm sure that everyone who have joined today for the session know more about that. There is nothing new for every one of us, but somewhere it would be more helpful for the family members to manage it at home. So pre-medications, if there are any SOS medications like morphine or the tramadol, before the procedure, try to administer that. So give a break of half an hour before. When you're doing it at 9 o'clock, start giving it at 8:30 a.m. So by 9 o'clock, the patient will be ready and there is no pain-free, and the wound dressing can be done well. Number 2, positioning and removal of dressing. Positioning, when we talk about that, sometimes when there is a patient who is semi-conscious, okay, follow the protocol, just put him in a side lying position and clean the dressing well so that uh, the body is not soaked well in the water. So only that surface area of the wound is been cleaned. If the patient is able to sit, okay, better go for using a bowl close to, if it is in the head, if it's a head and neck cancer, place it just below the chin and flush it well, so the water is not disposed everywhere. So that will be more easier. So removal of the dressing, as I told you earlier, cleaning the wound with the normal saline, flushing it well, and applying some medications. I'm going to talk about that later. Okay, apply new dressing. This is what the few steps of dressing procedure. There are a few points to remember is, do not apply cotton directly over the wound. I'm going to show you a picture in the next slide. So do not do the dressing when the patient is in pain. The patient is in horrible pain. Try to administer some medications and then go for that. If not, tomorrow the patient might not call you for the dressing. So it is very bad experience for many of us if we go for this. So try to manage his symptoms first and then go for this. And also the privacy. So it should not be in an open place where everyone is watching that, looking ugly, some twisting faces for the family members or not anybody in the society. So it should also be provided with the privacy. So that is more important at this time. So when you talk about the quality, everything will be considered in that. So let patient decide the time of the dressing. Each and everyone have their own ideas and concepts or the time of anything. So out of all these anythings, the patient can decide when to do the dressing. Early in the morning, I wanted the dressing to happen, and then I have to go out and sit and read my newspaper. Okay, that's fine. We can just prepone our dressing procedures and do it for the patient shake. And use washroom as much as possible. So patient themselves can go out to the washroom, who are able to walk around, so can go out to the washroom and clean it well and come back to us. So that will save our time, and also patient himself can do it once they go back home. Next slide, please. Okay, so there are some dressing equipments. I'm going to share that right now with you. So number 1 is about the hospital based. So in every hospital, we have all those equipments available, but somewhere I'm more concentrated on home based equipment, dressing equipments. So try to practice only with the available resources you have. So I'm going to show you all the resources which are available in the home setup itself. Next slide, please. Okay, there are few things which are been used in the hospital, not even in the home setups too. Number 1, a sterile dressing kit. I'm going to show you in the next few slides about the sterile dressing. So in the hospital, we have an autoclave machine that is easier. We have the pads and cotton available and gauze pieces, and we'll be sterile. The autoclave is done every day, and some way that will be easy for us. We have a bin ready, sterile dressing kit in the bin. And number 2, the warm water. So what's the major role of this warm water and salt and baking soda? So baking soda is not all the time. Sometimes we use it, unless salt plays a major role in cleansing. So warm water. So a liter of warm water with a tablespoon of salt and little bit of pinch of baking soda. So frankly to say that salt can help these kind of malignant and necrotic fungating wounds. Take out the slough, controls the bad odor, and also the salt is a very good neutralizer. So it doesn't have a major impact on damaging your pH of the mucous membrane. So that will be more helpful. Sometimes when we have a lot of throat pain, many of them use warm water with a little bit of salt. So salt neutralizes your pH levels in your mucous membrane. At the same, when there is an exposed wounds like this, salt controls the bad odor, number 1. So it is also a good neutralizing agent. It cleanses all the slough. It takes out all the waste particles from this. So once the wastage has been cleaned, once it is cleaned out, that will be more comfortable and the pain is bit under control. Like this concept can also be implemented in the earlier slides we have seen. We have seen 4 patients, out of which every patient can be used with that. So a liter of water, concentration is a liter of water with a tablespoon of salt is a regular pattern. So every time The patient need not buy the normal saline. In the hospital setup also, we do the same process, because if I start using normal saline in the hospital, the family go back and don't ever think about preparing the same concentrated materials at home. They just think about buying the medicines out. They feel that it is more comfortable and good enough than the preparations at home. But there is no big deals somewhere. If the water is warm, it means that it is active. It plays well when compared to the cold water. So that's the reason why we have a warm water. So we take a bucket of water from which the liter of water, or a bowl of water is taken separately. We add a concentration of water, of a salt to that, sorry, and this procedure is been done. So the whole program or the plans or the procedure is watched by the family members. Once they are stuck to this and they are used to that, they go back home and prepare the water. Water, salt, and baking soda is not expensive at all. Once you go up to the medical shop, and right now the normal saline or any other fluid bottles are more expensive. I'm not talking about day 1 or day 2. When you talk about the incurable illnesses, it will stay back for the long time till the death of the patient. When these are really the acute illnesses, or once we have an accident, you need not go for these kind of procedures. When you have an accident, just go clean it up with the betadine solution or apply some betadine ointment. That's okay, because those are going to get healed very soon. But we are talking about the chronic illnesses in which these kind of malignant fungating wounds might take out the patient close to the death with the poor quality, if that is not been managed well. So next is the metrogel. Okay, when we have a betadine and other antibiotic creams or the powders, why are we going up to the metrogel powder here? Metrogel helps in controlling the anaerobic infections. So the anaerobic infections are very well controlled with the metrogel tablet, crushing the metrogel powder and spreading all over the wound. So when this powder is applied on the wound, it really helps in controlling the anaerobic infections. So it binds up as a layer and tries to block the infections coming in. So it helps in that way. And a 10cc syringe. So these are all the kit what we have it ready for the dressings every day. So each patient have a separate kit ready early in the mornings. So we go directly to the patient, do the dressing, and come back with all the same thing, and everything is disposed later on. So 10cc syringe. So a 10cc syringe which has a needle, the needle to be bent to the half level 90 degrees, and this needle has to be adjusted to the syringe, load this normal saline preparation and flush it directly over the wound. So be careful that the needle should not be disconnected and may injure the wound. So be a little cautious about that. Hold it, grab it very well with your hand, number 1. Number 2, flush it in a specific area where you see a lot of slough or the minute particles which are to be cleaned out. So when you start using it, the pinpoint flushing can really help in cleansing the wound instead of pouring a lot of water on that. Or sometimes the patient can now go out to the washroom using a tap water directly flushing over that. It helps in cleaning the debris or the fungating layers which are present on that area. So once it is out of it, the patient will surely have be free from the pain, number 1, and also he feels more comfortable and infection free too. And number 5 is we'll talk about the sucralfate syrup. The syrup sucralfate plays a major role in controlling. Only thing is, if you find earlier in the slide you have seen a huge cauliflower necrotic bad fungating wound, it has bleeding. I'm not talking about the massive bleed. Somewhere arterial bleeding or venous bleeding cannot be stopped, but it is important for the family to be told about that. But here I'm talking about the superficial wounds. So there is a very minute bleeding happening. Syrup sucralfate local application with the good compression can really help in controlling I'm talking about the minor bleedings. A paper plaster after the dressing, it should be packed well. When you talk about this point, somewhere I see we get referrals from the other hospitals. The patient is referred here for pain management and also with the wound. So it looks very disgusting. So I thought that one day when a patient came to me, that was very huge. I thought that it is a huge dressing and we have preparation to be very huge too. And we all went there. And slowly when I'm just trying to remove the plasters and the layers of pads are coming out, and it is very just minute, not even the size of a tennis ball. It is more smaller than that. So such a small wound, the packing looks very big. So based on the need of the patient, and also based on the need of packing, you have to go forward for that, not to just make it a very big packing. Even for the dressing too, sometimes when there is a bleeding, try to compress that instead of using too many pads over that area. So compress it will apply pressure, and the bandaging should be with the proper pressured points. If you have that, the bleeding will be under control. Unless you put a lot of pads in, there are a lot of soaking. Again, frequently the dressing has to be changed, which is more uncomfortable for the patient. When also there is a bleeding, so it is hard for you to also take it out, and again the bleeding comes up. The more times you change the dressing, the more times the bleeding might be observed. So sucralfate helps in the other way, and the plaster, okay, only apply little plaster, and also the pressure source also may be developed with the like skin excoriations can also develop with a lot of plastering in that particular areas. The surrounding areas, when you put a plaster and take it off every day, the skin will be exposed for a lot of pressure, and it becomes dry, and you see a lot of skin excoriations happening there. Okay, try to involve the bleaching powder role every time when you do. So that is what we do here. We have a different bowls for each patient, also with the disposing covers for each patient. Once the dressing is over, we don't just throw it just like that. We also have those yellow bins and blue bins, but still all this dressing material are spread up with the bleaching powder on the surface, because we are sure that it will be exposed to some other people. So in our city, maybe if you have a good protocol and maintain it well, but people from the municipality, when they come in, they don't take it in that way. They just take everything, handle it in the same way. And sometimes the families also throw it in with the regular wastage in the bins, so which is very hard. So the bleaching powder plays a major role and very good disinfectant in controlling or spreading all those infections in. So once you do the dressing, you dispose all your wastage in the cover and spread some bleaching powder into that. This practice itself shows the family members also to do it at home. Like for the COVID, we do very good practices like hand wash, taking care of your mouth, brushing, usage of the mask. As the same, the family has to be more exposed in doing that. Sometimes even the family will be doing it, and the nurses will be observing that wound management. So if they face any difficulty, sometimes they get tense to do even to touch that. So they go back home. Who is more responsible person is a question. So family plays a major role. So family has to be taught more about this. So okay, next slide, please. Yeah, next slide. Okay, so applying cotton, it may leads to a lot of bleeding again in the future. So applying direct cotton over this, it forms as a layer. One day you see a full layer is coming out of that particular area, and sometimes it also bleeds even, and it is more painful too. So do not apply cotton directly. I mean that when you have a care plan, action plan in your file, the nurses are being taught more about that for sure. Number two, are the family well trained enough to do that? So in the hospital, it is easy for you to do. Appreciate that. Somewhere, the same patient goes back home and comes back to you with a lot of pain, and the patient is having maggots. How worst it is going to be. So nursing station or the nurses plays a major role in managing that, and also the doctor and the nurse has to educate the patient and family in managing the dressing at home. A social myth that in our state we see, they feel that it is also one of a different surgical wounds, nor any kind of other static wounds, whatever it is. They feel that when you just open it, keep it under the sun just like that, leave it like that, it becomes dry as early as possible. Do you think it happens? Not at all. They leave it like that. It was exposed to all the flies surrounding in the houses, and they come and get more infected. In the later on slides, we are going to see that. So these kind of myths are still there. They just leave it like that, and a lot of it is not an Ayurvedic to say even. So in the villages they used to do it. So they just collects all the leaves and smash it well and become a paste, and paste is just applied over that and wait for the result to come, which it really does not help them. But somewhere when you talk about palliative care, when it is in a starting stage itself, the family and the patient has to be taught more about how to manage this at home. Just tell them a simple techniques, step 1, 2, 3, 4, that's all. They have to go out to the washroom, flushing it, come back, use some metrozole powder over this, pack it well, done. That's all. You should not treat them in a different way that they will not do it anymore. Next slide, please. Okay, so pre-packed dressing materials. We all have it in the hospitals, but why not the home-based dressing materials is good enough for this? As I am talking about, these are the dressings which are necrotic, bad, fungating wound. Since the first slide, we are talking about that. When you talk about that, you really don't need very sterile techniques like a surgical wound. Surgical wound is going to get healed very soon. You should maintain precautions for that. You should have a very sterile techniques to do that. But when you talk about these wounds, these are going to get unhealed anyway in the future. But do not make it worse and should improve the quality. It just needs to be clean enough. Not the sterile I'm talking about. It just need to be clean enough. So the families are being taught, demonstrated well about home-based dressing materials preparation. I'm going to talk about that next. So remember, try to use locally available resources. Whatever is available in the patient's houses or the towns or the villages, whatever it is. Try to use as much as they have it. And these are all really to say aesthetically acceptable. So everyone have seen that and they feel that, okay, this is a good option and easy to use too. Need not worry about or wait for the nurses or the medical professionals to come in and do the dressing. Next slide, please. Yeah, coming back to the other thing, which is more important and everyone have to go through this. Maggots. So yeah, got it. We have 15 more minutes and I have very less slides too, sir. Okay, so maggots, it is one of the typical situation where the patient may develop just because of a very simple reasons that they just left it open and a lot of flies come in. They lay a lot of eggs into that and it just leads to a lot of larvae or the maggots coming out. Let's go back to the next slide and see what it is. Okay, this is a life cycle of an adult fly. Adult fly, it comes up to lays some eggs over that particular area, and these eggs hatches one day from the larval stage, comes back as a maggot from the pupa. So once it is coming out, so in the larval stage, it looks very small, and it becomes bigger every day, and it tries to bite all the skin, and it eats up all the skin and just makes it a more cavity inside. The patients and the family feel that I heard that one of the educated family said that all the maggots have come out of my mom's breast anyway now. That means that the cancer has gone out. This is the type of there are people like that who think in that way, and other people feel that it is all just because of the curse I have done long time ago, and I'm suffering like that today. It is just because of a flies coming out, and you just left your wound like that, unhealed, a very bad wound, left like that, and these flies have come up and laid legs, and you see those larvae coming out, which is called as a maggots. Next slide, please. The question is, how do maggots form? As I told you earlier, this is how when you just leave your wound open, it all happens. Followed by, is it a painful? Yes, it is. A lot of patients with the maggots experience a different type of pain, constant, around the clock. They experience a pricking type of pain. Something is biting them inside, and it too, it's a huge number. Like when you score the pain, it would be around some 7, 8, or 10. Sometimes the people even say that beyond that 10. So overall to say, it is more painful. The maggots inside may really lead to a lot of pain. So what measures to be taken in managing that maggots? We'll see that in the next slide, please. Next slide. Yeah. Okay. So medications for pain. We all know that when the patient is in pain, we start on the opioids management. So when you start giving the opioids to the patient, the pre-medications plays a major role. You may have to increase the doses of opioids what you give. Sometimes you may also need to put the patient on the subcutaneous injections to control his pain. And for the turpentine oil, the second point, turpentine. So sometimes it need to be diluted if required, and sometimes it can be the concentrated because it doesn't really mix up with the water. Just have a look at that. So, but sometimes you may have to be secured when it is close to your face. If that is a buccal mucosa, when you're dropping it directly into the throat, the patient may choke and get aspirated even. So prevent that, such kind of things. Be cautious about using the turpentine oil because it have a very pungent smell. Even when you just put little drops of turpentine oil in our room and just leave it like that, the whole room gets that powerful sprayed effect too. So you can't breathe in, suffocating. So when you put the drops of turpentine oil over the wound and wait for 2 minutes, so the maggots will not get the oxygen available inside because the turpentine binds the supply of oxygen. So it looks for the oxygen, rushes try to comes out from this wound, and then it is easy for you to take the maggots out. And as I said, secure the eyes if the wound is over the face. Gently remove the maggots using the tissue forceps. We have the tissue forceps available and try to remove that. Repeat dressing 2 times daily till the maggots are cleared. Maybe in the morning you have done today, maybe in the evening, try to look for the maggots again, because maggots still are in the body. It may lead to a lot of pain. Try to relieve the patient's suffering a lot as soon as possible. So till the time maggots are available inside, you may have to do the dressing twice or thrice daily, and start on antibiotics to control the infections, because the wound is exposed to a lot of infections. So antibiotics may help at that time. A clear explanation to the patient and family about the care to be provided at home to prevent the maggots. So the maggots presentation is just because of left it just like that. So explanation and education plays a major role in controlling this. Yeah, next slide, please. Okay, the question is, what if there is bleeding when the patient is admitted in home? The question is, can it be anticipated? You have seen in the earlier slides, there are 4 patients we have seen. Out of which, don't you think each and every patient will develop bleeding? Okay, and now the patient is not at your center or your hospital. The patient is somewhere at home, relaxed. They did not expect this kind of bleeding, and all of a sudden the patient have bleeding. So what are we going to do? What would be the good techniques or explanations helpful for the family members? Next slide, please. Okay, have a look at that. There is a picture which has been spread here. So the emergency bleeding kit in the hospital-based setup. So again, a tray or the box containing a dark cotton cloths. Have a look at the picture here. Dark cotton cloths. When you use a white colored shirt or whatever it is, the blood is exposed more when compared to the dark. To show you the picture, I have put the slide there. So dark cloths plays a major role. When you talk about that, a green colored cloths or any other dark cotton cloths would be more helpful. So the blood is not exposed. If we have such bleeding anytime, even a droplet also makes you more panic and anxiety. Even there is a minor bleeding out there, we'll be more in tension about that. If such patients have a massive bleeding every time, so that should be considered. So take a dark cotton cloth. When you're cleaning that wound, don't use a white colored pads or the gauze pieces what we have. Use some soft cotton material which is dark in color. Even though the blood is spread over that, so patient will not be panicked by seeing that, nor even the family, or it is not exposed to the other patients too. So in the hospital setup, these are the emergency drugs like tranexamic acid. Sometimes we give it in the IV route, and even the local application is also more helpful for our patients. I have seen an experience. There is a patient with the cervical cancer, and she developed a massive bleeding, which was not been controlled from morning till the evening. And her condition was really bad. It took long time for us to administer some adrenaline injection, soaked, packed well into the vagina. We just waited for a while, and by the same day night, I see that patient was more comfortable. There was no bleeding. So we have even tried the parenteral route too. Somewhere it is more helpful, and also the ethamsulate plays a major role in controlling the bleeding. Sometimes this midazolam, a short-acting drug, or the long-acting atovan also can be helpful in controlling the anxiety of the patients. Sometimes even not just the patient, but also the family will also be panic about that situations. So it's vice versa. Everyone have an impact on each and every aspect. So when the patient have bleeding, family is more anxious. When the family is more anxious, the patient will also have the anxiety level increased. So consider that well. So the patient and the family has to be taken care of in this. Yeah, next slide, please. continued metrosol powder, as I told you. So once the bleeding is managed well, controlled, we may have to just apply the sucralfate and the metrosol powder over the wound and packed up well. A gloves, ready-made gloves. So when there is a patient with in such condition, so bleeding, you need not go again and again. I see a lot of times our housekeeping team and I are rushing into the center and coming out and waiting for another drug to be waited. So instead, every time when we have a patient here, even though they don't have the bleeding, but what we try to do is we arrange a emergency bleeding kit ready at the bedside, because as an anticipatory plan, every patient will have the same thing. Even though there is no bleeding here, the patient is going home with all this material ready. So not the injections, but all the tablets are being given, all the gloves and safety measures for the one who is doing the attendant. Attendant safety is also important. A disposable kit is also been given to them, a polythene bag, and the material what is been spread over should not be thrown here and there in the houses. So which leads to more infections again. To prevent that, the patient's dressing material what been used out there should be disposed in a good polythene cover, and bleaching powder also very important, as I told you earlier how it goes on. Yeah, next slide please. I think we are running out of time some way. Okay, at home management, earlier we spoke about the hospital management of the bleeding kit, and here we see the tablet metrogel, and sometimes the injection metrogel. If there is a bad order, only then we can go for that, and syrup sucralfate, and gloves of 3 to 4 pairs of gloves. It is not just for one person to do it. So everyone comes out to help the patient at that time. So everyone should maintain that, because any body parts or the blood or any kind of body fluids is more infectious. So have to take care of that. Face mask and lorazepam tablet is also been helpful. Sometimes reduce the patient's anxiety. And I see when the boy had one of our patients who had a massive oral bleeding, the mother saw that situation and she became panic, and she did not sleep the whole day. And sometimes it is also been helpful for the family members sometimes. And dark cotton cloths, like I said, with the disposable apron, which helps them to not spill up on the clothes. A 10cc syringe and disposable covers and newspapers. So a lot of newspapers. Once it is helpful in just packing all the waste material and discard it. Bleaching powder, that's it. Yeah, next slide, please. Okay, so this is about the home-based autoclaving system. So I have just specifically mentioned the arrow marks there. Have a look at that. Okay, these are all the two bowls which you have to use. A small bowl with the lid and a large bowl with the lid. So large bowl, you may have to just use some cotton cloths, soft cotton cloths, like some saris or lungis, whatever it is. So those should be washed and dried well, and cut it into a small pieces and fold it well, and place it in the small vessel first. Place it in the small vessel, filled it up with the dressing material. And the large bowl, which I have mentioned in the below arrow mark, out of which take out the lid, put some water into that. So what to say, like 1/4 of water from this, 1/4 of water, and put it under the heat for next 10 to 15 minutes. And with which, at the same time, the small bowl, which is filled with the cut dressing materials, has to be placed into the large bowl. And there should not be a lid closed to that small bin. The small bin should be opened, and the large bin should be closed up with the lid. Wait for 15 minutes, take it out, and these in you can use it again and again. So based on the need and the requirement, prepare it on the basis of the functioning levels. If the patient really need a lot of pads every day, you may have to use it more frequently. If there is a less need, you can just prepare how much ever you want. So that is how the home-based autoclaving can be done even. Because I feel that family should not be dependable on somebody or going up to the medical shops. I see one single pad, which is 2 into 8 inches size, costs around some 35 rupees. Patient may need at least 5 to 10 per day. Just assume the cost of this, and talk about the normal saline, sucralfate. Everything takes a lot of time for them to, they can't even bear that. People in the remote areas, there are people who are with a very poor family background. They don't have money to eat even. Do you think these people can go out to the medical shop stores and get all these things available? Not at all. Try to use only the resources available at home. This is one of the best resources with which all the material can be cleaned well. Next slide, please. We are in the last slide of this. So patient may have the loss of self-esteem, altered body images also. So when you're doing the dressing, just talk about, so how do you feel when you have this wound? So the patient may come out with a lot of this kind of information. They are not looking for the scope of any big changes, but they just need somebody to talk to. So why can't the nurses or the doctor would be the same? So speaking difficulty, or is unable to open his mouth. If these are the specific issues for this patient, have a good plan, discuss among your team and try to help the patient. So take extra time to communicate with the patients at this time. Depression is also one of a common problem when there is a lot of disfigurement and a social taboo that the disease may spread to the others. So no one can come close to them, but somewhere we are here to help them. So that is the one of the important thing that maybe the patients who are in the depression has to be considered well, and anxiety, social isolation, withdrawal, and a lot of patients who are with the huge wounds are not kept in the houses. They will be placed somewhere in out of the house or in front of the house. So it's important for them, they need somebody to talk to them, somebody to discuss with them about their own personal wishes and happinesses. So the social isolation, withdrawal, and support the patient and family in all the aspects. So providing the kits or the equipments what we have, sometimes sharing the information, talking to them, say hi to them, how do you feel today? It itself makes them more comfortable. Not just the dressing, but we are just going beyond that level. Yeah, next slide. That's it. Thank you. I'm up with that.
Thank you, Swarup. So you can ask questions.
So the injection tranexamic acid and ethamsulate, are they all for packing, or are you going to give it as injections?
Yeah, tranexamic acid as a first line of drug we tried for the bleeding superficially as a local application. So
Okay.
so to say that maybe sometimes some situations, like I told you, even explained about that, if there is a spurting, or is it a venous blood or the arterial blood. So based on that, overall to say, if there is a bleeding again and again, the family has to be taught about that. The patient is not doing well and he is going to die. So our motto is to control the bleeding to some extent. So try using the tranexamic acid, the local application, and a lot of compression over that particular site, and that is, it is just a spurting. The sucralfate would be more helpful. So next line of drug would be that tranexamic acid.
So how much of sucralfate would we use to put over the area?
It is based on the size of the wound and wherever. Like you saw the wound in few pictures, no? Out of which there are splits of bleeding everywhere. So based on that, you may have to apply some 5 ml of sucralfate over that. And also here, the compression also comes in. So when you just apply it, compress it well, and the bandaging should be tight enough, and it should be comfortable for the patient. When you apply a lot of pressure over that particular site, it will be under control. I'm sure that this bleeding might happen again and again. So preparing the patient and family for the end of life is more important than this.
Thank you, sir.
So, Swarup, there is a question: will application of turpentine cause discomfort for the patient?
Sir, I didn't get, sir. Sir, I'm sorry, I'm on my phone. I couldn't see that. Can you just tell me again, sir?
Will the application
Can you
of
repeat the question?
turpentine cause discomfort?
It will not.
Yeah.
It will not really cause more discomfort because somewhere it is not a continuous process, and we are not using this turpentine oil over the superficial wounds. Mostly when you have maggots, it just means that it is called also a cavity wounds and the deepened wounds, and there is no real exposure of the skin out there. When you talk about the superficial, there will be no maggots even at that. So little drops of solution will not cause a lot of pain in that even. Sometimes it may have a lot of that pungent smell, and we are going to do that for next continued 1 or 2 days till the time where maggots are coming out. And there is no exposure of maggots again. We don't even need the turpentine oil. And it really doesn't cause pain. In my experience, that none of our patients said that turpentine oil is having a lot of pain. But when there is a bleeding and there is a lot of redness, you may have to think about it and a bit cautious about. Any other
Sir,
question?
one more question.
Yeah.
I didn't get the action of bleaching powder. I think I missed that. Could you
Okay,
explain
fine.
that?
Yes, ma'am. I'll just tell you. So, so it is a good disinfectant when compared to all the other what we have, phenyl or the Dettol, whatever it is. So, practices itself shows that even in the government hospitals, I see railway stations, everywhere you see the bleaching powder is spread like that, because lot of body fluids or urine, stool collecting at the single places from people from the different places, lot of infections are exposed. That is why we just spread people spread the bleaching powder just like that. As the same, when you talk about these kind of malignant fungating wounds, lot of infections might spread up there in the hospital setup. Even when this is been carried out and thrown out just like that, and the dogs just come up and open it and grab everything out there and spread all the infections just like that. To prevent these infections, the bleaching powder should be spread into the disposed waste material, body parts. So it binds up this spread of infections on that area. Even that it is exposed out there, so it will not spread anymore. So bleaching powder helps in controlling that infections.
Okay,
I hope you got
understood.
this.
Yes, yes. Thank you.
Can ivermectin be used for maggots?
Yes, sir.
Can ivermectin be used for maggots?
Ivermectin for maggots, I'm not sure.
Okay, so usually it is not needed, but some people use ivermectin as a single dose. Can be
Okay.
used if necessary, but we usually don't use.
Yeah.
And Dr. Sheila Rathod asks, her relative has developed a pressure sore. It's superficial, but since he has massive ascites, we can't turn him around. How do we treat pressure sore? There was a lot of veterinary preparation sprays which will cause maggots to leave the wound. Is there any such preparation for humans? So these are
I
two
hope the
questions.
frequency has
One
to
is-
be controlled. Like he need not get the dressing every day. Instead, we also have some soframycin ready-made gauze pads. So once you apply it, it can remain for next 3 days, because we are not dealing with fungating wounds here. It is just a pressure sore. So there are few pads which are available. So it can be fixed in there for next 3 days, and every third day it need to be changed. Instead of changing it every day, you can just use it for every third day. I used to do that when really the patient is unable to turn to the other side, and it is very hard for the family members or the staff to do it. So, okay. So this is how we can do. Number one is, I think this patient would be in a lot of pain even. Maybe the pain management followed by changing the positions. And also last 2 years ago, when I've been to Canada, they used to have a big net kind of thing. The four sides, the family or anybody, 4 to 5 members can hold it well, so that the patient can be turned out in a very good manner. So I thought about the positionings of the nurses and the staff, so that it makes easier for everyone to move up to the other side. So that's how you just have to, you can search for the position changings in the YouTube, man. Maybe that would be more helpful. So this kind of net practice would be helpful. And number two is a lot of pillows beneath the back, but also change the position of the patient more frequently. A lot of pillows help can also be there. Yes, sir. Please go ahead.
So the last question, which is better, waterbed or airbed?
Wow, we are up to the care of bedridden now. We are on the other side. Somewhere I see that when waterbed is expensive and airbed is also expensive, we are dealing with the patients who are very poor. Like a lot of our patients we see are from the poor financial status. And apart from that, forget about their financial status. Of all these, it can only help for a period of time. And number two, the good advantages of this is only 30%. Even though there are patients who are on the water bed, not on the air bed, still they develop bed sore for sure. 70% of patients will develop the same. So the response from that is very less. So compared to that, position changing plays a major role. Even though the patient is lying down on the floor, when you have a good change of positions, the bed sores will be, the patient will not have bed sores. So pressure will be relieved more frequently when compared to the airbeds. Sometimes airbed itself makes many of our patients very uncomfortable because it is not flat. It keeps moving in. The air moves in and out. Sometimes power supply, if there is no good power supply, that really creates a problem. If sometimes in our state we have more frequently in the villages, the power supply is going on. If that is how the situation, it doesn't work with this. The air compressor will not work. So on the other side, you see water bed, filling up water into that and transporting to the other places or changing the sites is more uncomfortable. Sometimes if there is any leakage into that, and it's all wasted and expensive too sometimes. So moreover, 70% of benefit is seen only by position changings. Use a lot of pillows, do some bridging techniques. A soft turkey towel, a soft cotton towel can be rolled out and placed underneath, just like a ring. That will be more helpful instead of this air beds or water beds. People feel that air bed is done. Okay, now a patient will not develop bed sores. But for sure, 70% of patients have developed bed sores, even on air bed, even on water bed. So that is our option. Yes.
Okay. So there is one more question.
Please go ahead.
Have you heard of Duoden? Duoden patch.
Duoden patch. I heard about that, but we don't use it. We don't get it available here.
So there are many types of patches available, which can be applied on the pressure sore, and in such instances that wound dressing need to be removed only after maybe 3 to 7 days. So there are many types of such things are available, but it is costly. So we have to stick to the locally available methods. So I think we have shooted our time. So thank you, Swarup, for being with us and taking
Thank you, sir. Thank you so much.
taking a very good session on bone management. Thank you very much.
Thank you.
And
Thank
thank
you,
you,
sir.
Dr. Jordan, and thank you all for being active. Thank you.